floor is yours.
Thank you. Thank you. Okay, so as Lori said, I'll be talking about yoga therapy and traumatic brain injury. And as we go through, I'll probably just be more focusing on TBI and not as much about what happens with stroke patients and things like that, but more about multiple concussions and that kind of perspective of traumatic brain injury. So defining a TBI. A TBI is caused by a bump, blow, or jolt to the head, or a penetrating head injury that disrupts normal brain function. Oh, that's not changing on this thing. Sorry, guys. The severity of a TBI may range from mild to severe, and as we go through, we'll see how that is determined. So there's two kinds of head injuries, a closed head injury and an open head injury. A closed head injury is a blow to the head, so that there's nothing actually penetrating the skull, but the brain gets knocked against the skull. And they can be diffused or local, or focal. Diffuse means that it can affect more than one area of the brain. Focal meaning it's just in one localized area of the brain that gets affected. Common causes of that: auto accidents, assaults, and falls. Falls are really a huge percentage of how people get traumatic brain injury, and you'll see that later. Work-related accidents, sports-related accidents, and again, closed head injuries can also range from mild to severe. And then open head injury, this is where the object actually penetrates the skull and enters into the brain. They're usually in just one place. As you can tell, like the brain's doesn't get shaken against the skull, so it's usually just, if something were to penetrate your head and go through your skull and enter your brain, it would just ping into one part of your brain. And obviously they can be very serious, and depending on how severe, it can cause death. So things like bullets, knives, skull fractures, if you get into a car accident, an object actually penetrates your skull, goes into the brain. And then again, sports-related, athletic-related injury can also have something be an open head injury, or cause open head injury. So two kinds, contusions and concussions. We hear about concussions a lot, but what really are they? Concussions are wide-reaching injury due to the broad-scale trauma. So they generally are diffused, again, meaning that they affect more than one area. And a contusion is a localized injury. It's comparable to a bruise. So you get a bruise on your shin, you hit your shin, you see the development of the bruise. It's just in that one point, and that's very similar to a contusion. If you have a concussion, you can actually have multiple contusions, right? You can have multiple bruises in your brain, let's say. So some statistics, I actually didn't know this until I started researching how prevalent TBI actually is. So about 1.7 million TBI injuries are sustained yearly. That's a massive number. 52,000 people die, and 275,000 people are hospitalized from traumatic brain injuries. This contributes to 1/3 of all injury-related deaths. So a lot of injuries also result in have a traumatic brain injury component to it. So somebody falls, they might break their arm, but they also might have hit their head, for example. And then a lot of times, that's not really looked at. They fix the arm, but they're not really sure what's going on with the rest. So maybe later on somebody's having symptoms of depression or anxiety, and it's not tracked back to the accident that they might have had that broke their arm or the car accident that they were in, because they might have suffered traumatic brain injury that's been undetected. And that's a huge reason why there's probably a lot of deaths from this situation, because it goes undetected, especially if it's not an open head injury, right? So about 75% of concussions or other forms of mild traumatic brain injury. So that's a huge percentage as well. Concussions, again, that can affect lots of different areas of the brain. So you don't really know what symptoms will be showing up, because, again, again, could be in a lot of different areas. So how big is the problem? Again, just going over some statistics. You guys can look into this more on your own. They're obviously all part of your slides. And I included a lot of these facts because I know that a lot of us haven't had experience with working with traumatic brain injury, so I wanted to give you guys as much information as I felt would be useful to you. So if you ever run into something, you can just have some knowledge and some competency about the issue. So in 2010, I know a few years ago, about 2.5 million emergency visits, hospitalizations, and deaths were associated with TBI. TBI, again, contributed to more than 50,000 deaths. And then over the last decade, TBI-related emergency visits increased by 70%. That's a huge number. And hospitalization rates increased by 11%. Very prevalent in children as well. About 250,000 children were treated in the US for either rec-related injuries or athletic-related injuries that included a concussion diagnosis that can be tracked to, or a TBI. And then 2001 to 2009, the rate of emergency visits for sports and recreation-related injuries alone or in combination with other injuries rose about 57% among children ages 19 or younger. And a lot of money, right? In 2000, direct and indirect medical costs of TBI, because when people have TBI, again, we don't know the symptoms necessarily that are contributing. So lots of loss in productivity, people aren't going to work, they're not employed, this could be from depression or whatever else, but all related back to this injury, totaled $60 billion. That's an insane amount of money from people just not, working and contributing to society, not maybe spending because they're not having. So again, some more statistics, but really this is for you to read over, and I would just like to show you this chart because it's just a good image of what, where everything falls in line. So falls 40.5%. So a lot of the majority of why people get TBI is because they fall down, they hit their head, they trip on something, they get tackled in football, whatever it may be. Motor vehicle, auto accidents, right, 14.3%. Assaults, getting hit, punched, 10.7%. Struck by or against, 15.5%. And then unknown, right? So somebody might have come in with another injury. They might not know why they got the TBI because they might have treated the injury and not even know that the TBI was there. 19%, that's kind of like the miscellaneous. But mainly falls. A lot of people fall down, hit their head, or for whatever reason, kids falling in the playground and whatnot. Statistically, men are more common to suffer from TBI than women. You can see all these different scales showing emergency visits, deaths related by male or female by sex, hospitalization by sex, and this is the emergency visits and hospitalizations and deaths from years 2001 to 2010. And again, men in every category exceed women in this strategy or injury. So 4 categories of signs and symptoms. So before we get into that, I just want you guys to know that 20% of the body's energy actually goes to serving the brain. 3% of our body's weight actually goes to the brain. So if we think 20% of all of our energy goes to serving the body's brain, there's going to be a lot of fatigue that's going to show up with people with traumatic brain injury. Where else does fatigue show up? Fatigue shows up when people are stressed. Fatigue shows up when people are depressed, are anxious, right? So again, very ambiguous types of symptoms that don't necessarily mean they have a traumatic injury, but also don't necessarily mean they have the other illnesses or ailments as well. So kind of stage 1 would be the first. If you have difficulty thinking clearly, you might have a slight headache, little fuzzy or blurred vision, emotional mood. Again, this is kind of going to depend on what part of the brain is affected, but irritability, frustration, and then that could be like, oh, because I have a headache, like I'm annoyed or irritated, right? So again, very ambiguous. Sleeping more than usual, fatigue, right? Feeling slowed down would probably be step 2. Again, that's that fatigue showing up. Nausea, vomiting early on, dizziness, some sadness there, sleeping less than usual. And we talk about being hyper tired, right? If you see a little kid and you're like, they're jumping off the walls, it's like they're overtired. So we can see the extreme of that would be not sleeping as much, but it's really because they need a nap. So it's kind of a good way to think of it, just over fatigue. So difficulty concentrating would be another kind of category. If you start to have sensitivity to noise or light, again, could be caused from headaches or migraines, right? We don't know. Balance issues, more emotional, trouble falling asleep. There's that overtired again. And then difficulty remembering new information, fatigue, lack of energy, anxious, nervousness. We see fatigue in every single part of this categorization of signs and symptoms. And again, we don't know if it's from that, if that's the root of the issue, or it's just because people are overworked or stressed or whatever else they're going through. So the ambiguity in diagnosing a traumatic brain injury I believe, is a huge factor of why they're misdiagnosed and why people go on certain medications without ever feeling better. So a TBI may lead to a wide range of short and long-term issues affecting cognitive function, motor function, sensation, emotion. And again, approximately 5.3 Americans are living with a traumatic brain injury-related disability. And the consequences of severe traumatic brain injury can affect all aspects of an individual's life, including relationships, work, household tasks, driving, etc. That, again, depending on what part of the brain is affected, people can have trouble getting dressed in the morning, people can have trouble making coffee in the morning, and let alone how they interact in the personal relationships, work relationships, whether they even feel like working, and so forth. So the different tests that will show or determine, or how it's determined that you have a traumatic brain injury. One is the Glasgow Coma Scale. And this is the most common scoring system. It's used to describe one's level of consciousness and gauge severity in a person following a traumatic brain injury. So the things that they test for are eye-opening response, verbal response, and motor response. So for each of these categories, they actually all have their own numbers. So eye-opening is 1 to 4, verbal response 1 to 5, motor response 1 to 6. For example, in eye-opening, they'll test whether 1 would be you don't have, your eyes are completely closed. They all start out with 1 being no response, so there's nothing happening. And then they go up from there. So things that they would look at for eye-opening is whether you, how you are looking around the room. Verbal response, do you have like disorientation in your language? Can you actually have a normal conversation? Motor response, what's your posture like? Do you have, are you focused on pain, whether it's localized pain, are you withdrawn from pain? So it's kind of interesting, there's a broad variety of ways that they test, but it's 1 to 4, 1 to 5, and 1 to 6. And the lowest number you can get is a 3, right? Because if these are all 1 being no response to anything, then you have a 3. So that would be very severe. The higher the number, the less severity your injury. And it's 3 to 8 consists of a severe injury, 9 to 12 is a moderate injury, and then 13 to 15, if you score 13 somewhere between there, it's a mild injury, according to this model. Also going back just for a moment, can I go back on this? Well, yeah.
Look at the back, maybe the back arrow.
Or look at the delete.
Yeah, you can press S.
Okay. I don't know where the back is.
Oh, it's the PBL.
Okay. Yeah, it's the okay, so going back to the Glasgow for just a moment. Okay, there are limitations to this model as well. If the person is drug or alcohol intoxication, if they've had shock or they have low blood oxygen, are all going to alter their consciousness. So there could be some ambiguity around whether the severity of the injury dependent on those things as well. So those are all taken into account. So there are some limitations, it's not 100%. If somebody has a severe, it might be more moderate depending on if they were drunk or something or had substance abuse in their system when the injury might have occurred So other things, imaging tests. This is actually one of the things that my personal case study went through to, she got a functional MRI which showed the damage to the frontal lobe. But imaging tests, so you have a CT scan, we're all kind of familiar with that phrase, and that's a scan that uses a series of x-rays to create a detailed view of the brain. It can quickly visualize fractures, uncover evidence of bleeding, so any kind of hemorrhaging, any hematomas, bruised brain tissue, right, contusions that we talked about, and any kind of swelling that might have occurred. Magnetic resonance imaging, MRIs, we also know that term, uses powerful radio waves and magnets to create a detailed view of the brain. And this test is used primarily after the person's been stabilized. So you're not going to put necessarily somebody in a coma through an MRI. So again, going back to brain swelling, intracranial pressure monitor, that's going to be used to determine the tissue swelling as a result of the TBI. And it's really important to monitor that pressure. A neuropsychological assessment is also very, very useful when somebody's been diagnosed with a traumatic brain injury. It's a range of psychological tests that objectively measure the brain function. And it'll show and determine what areas of the brain can be affected because it measures the functions of the brain. So attention span, orientation, memory, concentration, language, how receptive or expressive the person might be, spatial perception, abstract and organizational thinking, problem solving, social judgment, motor skills, sensory awareness. All these things can be affected depending on what part of the brain or multiple parts of the brain that are affected. So before we get into the frontal lobe, true or false, we only use 10% of our brain. False? False.
True.
True. Okay, so it's kind of a split, right? Some of us think we only use 10% of our brain, and some of us don't. It's actually more likely that we only know 10% of the brain's use. As we go through and as we see the different areas of the brain, no part of the brain is redundant. We actually use 100% of the brain, and we use 100% of it every day. So, right, kind of interesting. So you could see, because, okay, so if that was true, that we only use 10% of the brain, this is kind of what I have to put into perspective. If a part of our brain was injured, then we should pretty much go on through life if we don't use that part of our brain unaffected, right? Because we only use 10%, so what does it matter if we just lost that part of our brain, right? But that's not true, because even if you do damage just a little portion of your brain, depending on whether it's mild to severe, you will see effects from that. So the frontal lobe, most common injury because it's right here. So right under the forehead, as you see in the picture, it's considered our emotional center. This is our home to our personality. Very essential in yoga that we're connected with our frontal lobe. Involved in motor function, problem solving, spontaneity, memory, language, initiation, judgment, impulse control, and social and sexual behavior. They also have asymmetrical differences. So the left side is involved with more language-related movement. What do I mean by that? Any movement that involves language, and that would be more like waves and gestures, for example. If you're relating language to movement, like a hello, right? You do this and you know that that's a hello for me. A gesture, right? I nod and you know that that's a yes or a no, so there's difficulty there. And then also expression, so it plays a role in nonverbal abilities. So if I'm like this, you guys can tell I'm like disgruntled or annoyed, but I might not have those skills anymore if I've damaged the right part of my frontal lobe. One of the most common effects of can be dramatic change to social behavior, again, because it's playing a role in our emotional control center. It may play a part in spatial orientation, including our body's orientation in space, and impact on divergent thinking, flexibility, problem solving, and so forth. So some of the observed problems: loss of simple movement of various body parts, loss of spontaneity, cognitive flexibility, which we use quite a bit with mindfulness, right? We hold two things in space, two opposing thoughts, two opposing beliefs, inability to focus on a task, mood changes, difficulty with problem solving. You guys can read through some of these in more detail if you'd like. But number two, the inability to plan a sequence of complex movements, things that we take for granted, like making a cup of coffee in the morning or backing out and driving to school. Those could all be, because those take a lot of cognitive energy, so those could all be affected. Parietal lobe, two functions is integrate sensory information to form a single perception. So that would be more like language processing, how we process language to form a single thought, and then construct a spatial coordinate system to represent the world around us. A lot of individuals also with this kind of damage will have trouble with sense of touch, not knowing about pain or temperature. Again, we kind of talk about that with motor function, with the Glasgow scale, right? They would test if somebody is withdrawn from pain or reacts to pain. Also, spatial awareness is included in here, so our proprioception, where our body is in space. There's different asymmetrical differences. Left lobe damage, Jersten syndrome. So that can sometimes have symptoms of aphasia as well, which is the difficulty of self-expression, understanding speech, writing. And Baylan syndrome. Baylan syndrome generally occurs if there's been 2 or more strokes, and if those strokes have affected the same portion of the brain multiple times. So it's very rare, and actually very, there's still a lot of ambiguity around this particular disease. It's not fully understood, but that is a possibility, and it's also very severe. Again, observed problems, things that you would see or be looking for parietal lobe damage, the inability to attend to more than one object at a time, the inability to name an object, right? We're talking about language, how to form a single perception. So difficulty with drawing, reading, distinguishing rights and lefts, difficulty with mathematics, lack of spatial awareness, inability to focus your visual attention, and difficulty with eye and hand coordination. Occipital lobe. So this is at the back of the head. It's the center of our visual perception. This is eyesight. It's how we assimilate the information from our surroundings. Some observed problems here would be hallucinations or illusions, difficulty locating objects in the environment, right? Not being able to assimilate into our surroundings, difficulty with identifying colors, the inability to recognize words, difficulty recognizing drawn objects, difficulty with reading and writing, and so on. Temporal lobe, side of the head above the ears, involved in the primary organization of sensory input, highly associated with memory skills. Visual memories are part of the temporal lobe, language competence, and that could mean that you could have some difficulty with sentence ambiguity. What do I mean by that? I mean that if a sentence can have more than one meaning, it's the inability to distinguish what that sentence really means. And emotional associations as well. Again, left lesions and right lesions, what happens if you have them one on one side and one on the other, and the differences asymmetrically. And then again, observed problems, 8 principal symptoms of the temporal lobe damage: disturbance of auditory sensation and visual perception, difficulty with the identification or verbalization of objects, the inability to categorize objects, disturbance in the language comprehension, impaired memory, altered personality and sexual behavior. Brainstem. So brainstem is, very important, connected. It's a big connection to the rest of our body, basically. So it's deep in the brain. It leads to the spinal cord. The brainstem plays a vital role in all of our basic functions. So basic attention, arousal, consciousness. All the information to and from our body passes through the brainstem on the way to or from the brain. We had a question when we were on our call about breathing patterns. Well, that would happen if the brainstem or the medulla oblongata located in the brainstem were affected or damaged. That's in charge of all of our involuntary functions, such as breathing and regulating blood pressure. Another one that we hear a lot about in yoga is our vagus nerve, also located in the medulla oblongata. So that vagus nerve can be damaged and affected. That sends a lot of fibers, basically it's from our brainstem all the way to our colon. And if that part of our brain is affected, it's massive for the rest of the body. So again, observed problems, swallowing food or water, right? These are all of our basic functions we take for granted every day. Basic problems with balance and movement, sleeping difficulties, decreased vital capacity in breathing, all these types of things. Actually, in the handout that was posted onto Blackboard, you can see a lot of the breathing patterns that can be disrupted. Most of them are from strokes, so I didn't include them in here because I didn't feel it was super relevant to what I was talking about today. But you can look through that because we do get a lot of stroke patients in yoga, people that have suffered from strokes, and breathing patterns there can be there's different types and generally what they're caused by. So the cerebellum is at the base of the skull. It's involved in coordination of voluntary motor movement, balance, equilibrium, and muscle tone. Some observed problems here: lost the ability to walk, right? Muscle tone and also basic functions, lost the ability to coordinate fine movements, inability to reach out and grab objects, tremors, vertigo, slurred speech, and the inability to make rapid movements. Here's a little picture of kind of where everything is in the brain. If you ever want to go through your notes and scan this quickly to be like, what did she say? You can come here. And this will just give you like a nice little abbreviated version of what areas do what. And as you see, we use 100% of our brain 100% of the time, every single day, to do things. And the observed problems here. Oh, why are they going backwards? Okay, there we go. So I just really like this quote from the Center of Neuro Skills because I really thought it blended what we think about in yoga therapy as well, and we are viewing a person and using our tools to support their system. It just says, obtaining a general understanding of the brain and its functions is important to understanding the rehabilitation process. It's very important, however, to understand the rehabilitation professional is concerned with the whole person, right? The identification of individual problems gives the rehabilitation team areas in which to focus treatment plans. All of these plans are designed to work toward the rehabilitation, again, of the whole person. We're not just treating an injury, we're not just treating the affected areas. Each problem area affects other areas, and many times resolving one problem has a major impact on all the other problems. We see that all the time, right? Sometimes we just correct somebody's breathing and suddenly they have more energy, suddenly they feel stronger. So we see how one area just trickles down like the domino effect to all the other areas of the body or the person's treatment. So initial treatment just varies again on how severe or mild the injury is, but the treatment's based on the severity of the injury, what areas of the brain are affected, what pathways have been affected, what pathways have been broken. Sometimes if it's just mild, you'll just rest for a few days, probably be monitored, and take some over-the-counter headache medication. Moderate to severe can range from emergency room. You can end up having a whole team needing to help you if you have, depending on the severity of the injury. Which brings us to the rehab team. So a rehab team can include physiatrists, neuropsychologists, right? We went over that neuropsychological test to determine the brain function. Physical therapists, occupational therapists, speech and language pathologists, traumatic brain injury nurse specialist, vocational counselor, and a yoga therapist. So you can read through and see what each person's duty is, but it really does take a team sometimes to rehab these people, and sometimes these are lifelong members of their team and in their life. So I found this article really interesting because a lot of what we talk about in yoga therapy is not going for acute, but rather going for chronic, right? Chronic disease. And this is how TBI can be and should be considered a chronic disease. TBI is a chronic disease process that fits into the World Health Organization definition as of having one or more of the following characteristics. It is permanent, caused by non-reversible pathological alterations, requires special training of the patient for rehabilitation, and may require a long period of observation, supervision, and or care. It increases long-term mortality, reduces life expectancy. It's associated with increased incidences of seizures, sleep disorders, neurodegenerative diseases, neuroendocrine irregularities, and psychiatric diseases. TBI can affect non-neurological disorders such as sexual dysfunction, bladder, bowel incontinence, systemic metabolic dysregulation that may arise persistent for months or years post-injury. So these are all the things, again, that can come up from exhibiting a TBI. You might have a TBI 5 years ago and suddenly be feeling depressed, 5 years later and not know why. And it could be just these symptoms of this chronic disease showing up. So some statistics here about mortality and morbidity rates to prove that TBI is it should be considered a chronic disease. Recognizing the chronic nature of TBI can lead to government and private funding agencies to help aid in research. Post-traumatic mortality studies have shown that individuals who suffer from moderate to severe TBI are so for 37 more times likely to die from a seizure, 12 more times likely to die from a blood infection, 4 times more likely to die from pneumonia, 3 times more likely to die from other respiratory and circulatory conditions, and significant reduction in long-term survival. So an average decreased life expectancy of 7 years for those victims. Again, just some more statistics on what their increased risks are of developing certain psychotic diseases or psychological diseases such as OCD and anxiety, metabolic defection, muscular dysfunction. TBI nutrition, really important. We talk, Elia brought up this in our call about diet. I didn't even think about it at the time, but it's actually a huge proponent as to the rehabilitation process of somebody with traumatic brain injury. So post-traumatic brain injury patients typically experience a need for nutritional support because of all these things that actually happen when there is this injury. Hypermetabolism, weakening of the immune system, needing to strengthen the immune system, immune modulation, modulating it, building up its nourishment, free radical generation, and oxidative stress. So oxidative stress, I didn't know what that was, so I myself too had to look that up. I was like, what is that? Very important. It's an imbalance of free radicals and the body's ability to be able to fight and detoxify those free radicals. So typically, free radical generation, right? More free radicals are being produced, and now you have this imbalance of the body being able to fight them off. And that leads to something called lipid peroxidation as well. They kind of go together, which basically is, we'll get into it, when the cell is being derived of nourishment. Ischemia, blood O2, so ischemia is an inadequate blood supply, so shortage of oxygen, and it needs glucose to keep the tissue alive or the tissue will die. And then again, neuroinflammation, so inflammation of the brain. We showed a test earlier that helps determine brain swelling. And then lipid peroxidation, which we'll talk about here, is when the free radicals steal electrons from lipids and it causes cell damage. So really important. So our brain is actually made up of 60% of it is fat. So omega fatty acids, really good to support fat content of the brain. Defend against lipid peroxidation, oxidative stress, and inflammation. Glutamine serves as an essential function to stabilizing mood, easing symptoms of depression, moodiness, irritability, anxiety, sleepiness, and alter the effects of trauma. Ever since I read that, I started taking glutamine. It's like, I need that. Nitrogen is necessary to repair the wounds and keep the vital organs functioning. 1/3 of this nitrogen comes from glutamine. Antioxidants. We talk about fighting free radicals and the brain needing support for that. There's where the antioxidants will come in to reduce that oxidative stress and help prevent chronic disease. You can get that from vitamin E and C, beta-carotene, green tea, ginkgo, niacin. Choline, that's actually found in egg yolk, and it reduces neuroinflammation. Creatine protects against ischemia, that oxidative stress showing up again. Magnesium to support the central nervous system after traumatic brain injury. Vitamin D and progesterone as anti-inflammatory, again, reducing that oxidative stress. And zinc. We all like to take zinc right before we feel like we're getting sick. Yes, because it helps support the immune system. It's critical for tissue repair and essential enzyme function and gene expression. May reduce development of behavioral deficits in traumatic brain injury patients. So traumatic brain injury and emotions. What happens and why? Because it depends on where you get injured, commonly in the frontal lobe, which is our emotional center. So you can see things like mood swings. That can occur with no specific trigger and without control, so people can just be happy and sad, and angry and sad, and switching back and forth without really any reason or trigger. Anxiety, very, very common, may occur without exactly knowing why, may become anxious about falling, also about failing at a task. So being criticized, overwhelmed, re-injuring themselves, being in crowds, being rushed, adjusting to sudden changes in plans. Things that require a lot of attention and information processing can cause anxiety. Depression is also very common. These feelings appear during or later in the stages of recovery after the individual has become more aware of the long-term situation. They get depressed about their loss, about their maybe not being able to do the things they used to do, not being able to find work. Emotional stages of recovery very similar to the emotional stages of grief. So denial, anger, bargaining, kind of that desperation that they'll do anything to get better. Depression, the hardest emotional stage to work through because it does require that little bit of acceptance as we move through the rehabilitation process. And then hopefully, eventually, however long that may take, they'll reach acceptance of what has happened and be able to push forward. So for the last 15 years, the attention and focus has increased toward the internalizing problems. Mainly people have been focusing on the externalizing problems, such as the things that you can see, right? All the functions that are now disturbed. Well, they see the emotion, how important it is to focus on the internalizing problems that are caused from TBI, anxiety, depression, and fear. And there's been a big switch into focusing on those as well. And that's why before I said insert yoga therapist here, because this is where we can come in and play a really nice role, not necessarily psychoanalyzing somebody, but helping them move through those stages of emotional recovery, or those stages of grief. It's like you've lost something, that sensation of not having anymore. And then again, these internalizing factors and problems can be chronic, right? People can have this anxiety and fear from that traumatic stress. So mindful-based stress reduction therapy, we've known about mindfulness meditation, we hear that a lot. So it's a group program, it focuses on the progressive mindfulness-based modality, right? John Kabat-Zinn. Moment-to-moment, non-judgmental awareness. Experimental learning paradigm, these are things that have been used in case studies to help with those internalizing factors to help mitigate that. The experimental learning paradigm, developed by David Cole, and it basically looks like this. It's concrete experience, doing or having an experience, reflective observation, moving into abstract conceptualization, that's learning from the experience, concluding what you've gotten from the experience, active experimentation, right, trying what you've learned out, and then moving back. So you have the experience, you review on it, you gather something from it, learn from it, right? And then integrate it into your life. Sounds like yoga. Sounds like yoga to me. Acceptance and commitment therapy, ACT. So this, we talk about, or it's been spoken before, that there is this fine line, like what's in our scope? Cognitive behavioral therapy, well that sure looks a lot like yoga stuff. Right? Well, that's true. It does, because there is a lot of that yoga stuff in here. A lot of these psychologists or psychotherapists have traveled to India, read upon Eastern modalities, and integrate them into a more of a Western model fit for a Western society. So these are some of one of the ACT is one of the things that I really found was really relatable to the sutras in a lot of ways, developed by Stephen Cave. There's 3 core components of it. And it's basically choosing valued life directions, taking action in your life. And there's 6 core principles. Learning to accept both positive and negative feelings, cognitive diffusion, that's basically detaching from thought, being present in the here and the now, that's really a familiar one for us, right? We hear that a lot in our modality. And interacting with experiences and environment in a non-judgmental way. Patients learn to view condition as one aspect of their life, right? It's not who they are, it's a separate experience. It's not their pure being. Addressing values as chosen qualities. Well, that's kind of like the yamas and niyamas, and the yamas and the niyamas in a lot of ways, right? The do's and the don'ts. How do you want to be in the world? What are your life values versus what are your goals? Goals tend to have an endpoint, whereas the value is who you want to be every day in the world. And then committed action, integrating that, right? Integrating that into your life, being the yoga. We always say yoga is not something we do, it's who we are, right? So again, taking some of those experiences that we've learned through meditation, watching our thought, and integrating them into our life so we can be and live our values. and not our goals. In regards to that, it's kind of like discerning between, so when we talk about cognitive behavioral therapy and we sort of like, what's in our scope? Like, we can't do that, we're not psychologists, right? So I was in this weekend with Julie Carmen, and I kind of posed this question to her, being somebody of both modalities, and she brought up a really good point. And what she said is that we might know the intervention tools, right? We might know how to guide somebody through a meditation process, but it's discerning between knowing how to apply the intervention and being able to assess the full scope of who we're talking to. So we can apply the intervention, somebody comes to us with anxiety and fear, and we know the intervention. But we might not know that they may be schizophrenic or bipolar, and it's being able to discern that we're not diagnosing what we might think their psychosis might be, if they even have any, but we're applying the intervention on the symptoms, right, to support them for healing. So some studies that we've done, pilot evaluation of mindfulness-based intervention to improve quality of life. Quality of life is generally diminished when people suffer from a traumatic brain injury. The objective here was to improve quality of life, reduce depressive symptoms, typically those go together, and increase the sense of control patients experience over their own lives, right? Not feeling like they're in control. The intervention concluded insight meditation, which is mindfulness, breathing exercises, guided visualization, and group discussion. Because group talk can be really, really effective, especially when you're sharing in front of a group of camaraderie, everybody's kind of experiencing the same things. It can be very effective with your own personal practice. Unfortunately, a lot of our studies didn't have that many participants because it's still something that's being new, but good results. Overall quality of life was improved, and that goes hand in hand with kind of reduction of depressive symptoms. If you're not feeling so depressed, then you'll probably have a better quality of life. And there was a significant decline in cognitive-related mood symptoms. And these results were sustained over a 1-year follow-up. So again, teaching tools for people to integrate in their life, not just giving them a treatment for a 3-week or 12-week or 10-week period, but actually giving people something that they can use forever and maintain the results. Another study, reducing symptoms of depression, right? We said that that was a big one to overcome when we looked at all the emotions that people go through. So this involved meditation techniques, breathing exercises, gentle yoga, gentle asana, awareness of thoughts and feelings, there's that mindfulness showing up again, acceptance and staying in the present moment. They were recommended to have a 20 to 30 minute daily meditation home practice. Intervention was customized to address problems associated with traumatic brain injuries such as attention, concentration, memory, and fatigue. And when I talk about fatigue, it's not just physical fatigue, it's cognitive fatigue as well. Just to put that out there. So results for this, they used the Beck Depression Inventory to find the scores. It found there to be greater reduction of depression in the intervention group versus the control group. And again, this was also maintained at a 3-month follow-up. Respiratory, physical, and psychological benefits of a breath-focused yoga for severe traumatic brain injury. And if these people are severe, a lot of them are could be in chairs as well, wheelchairs, if they've lost their ability to walk. So 10 individuals, 6 males, 4 females to attend weekly 30-minute yoga classes over a 36-week period, so a little bit of a longer duration to increase breath ease, awareness, and promote relaxation. What they were looking for was the strength of exhale, the ability to hold the breath, or the tone, right? Breathing rate, counted breaths, heart rate, and self-reported physical and psychological well-being. Self-reported. So they didn't do a psychoanalytical test, but it was just coming from the student themselves or the participant. So again, we talk about that some people might be in wheelchairs, so a lot of their intervention was also modified for people in a chair. So a modified sun salutation in a chair, a seated twist, held for 3 slow breaths, modified side stretch and forward bend, pranayama, and I believe in this particular case study, Gary Krassaw interjected some of the pranayama tools and methods that were used, kind of contributed his say on that. So pranayama included breath of fire, lion's breath, counted inhalation and exhalation. We talk about ratio of breath quite a bit, extended exhalation or long enough, right? With the goal of increasing the length of each breath and ultimately increasing lung capacity and sound on exhalation, as we know that helps lengthen. So this was to help build stamina, strengthening the abdominal, strengthening the diaphragm, and concluding chants that could be sung in one breath were selected to increase respiratory capacity. So again, the intervention group had significant improvements in physical functioning, again, self-reported emotional well-being, overall health, and decrease in self-reported pain. The control group also felt an increase in physical functioning and improved general health, but they didn't talk about their self-reported pain or just overall emotional well-being. And I included this other case study just because it talked about mental fatigue, that cognitive fatigue that is very draining. The measures were self-assessment of mental fatigue, depression, and anxiety levels, and then the neuropsychological tests. 8-week program with a 2.5-hour group sessions. The intervention here was body awareness, body scanning, right? We talked about that loss of spatial awareness or proprioception, seated meditation with awareness to the breath, emotional and mental state. There was a one-day-long silent retreat incorporated here, which is pretty intense, between session 6 and session 7. And then these participants were required to do a 45-minute home practice 6 days a week. The results, participants experienced significant improvement in mental fatigue syndrome and in neuropsychological tests. So they actually did, it wasn't self-reported on the neuropsych aspect, so they actually did a test and had greater cognitive functioning, because that's what measures brain function. Decrease in tiredness, mental fatigue, mental recovery, slowing of thinking, sensitivity to stress, decrease in irritability and lack of initiative, increased processing speed, no significant changes in working memory or reading speed, but the mindful-based stress reduction may be effective due to the strategies offered to manage stress, as we know, and reduce or economize with mental energy, being able to use your mental energy more efficiently. So that was actually interesting. Going back, physical movement of walking meditation were found to help focus attention and keep participants more alert or awake. If you're doing something with a TBI patient that is now an automatic function, such as walking, it can actually increase their energy. They don't have to think about it. So it actually can be, instead of saying, oh, like you need to rest, like actually walking around can boost someone's energy because they're kind of zoning out. They don't have to use the fatigue, and they can actually gain some things from that. Okay, so I spoke with a speech pathologist. She actually specializes in cognition. She wrote a book called When Simple is Hard and Strategies for Thinking and Memory. She was actually a speech pathologist that my patient worked with when she was going through the more severe parts of her healing process. And she's the one that actually told me about cognitive fatigue and how big of a role it actually plays. So she works with high-level brain injury. Most of her patients have taken I've seen a neuropsychologist and have taken the neuropsychological test. So she teaches her patients tools to fix and reconnect the damaged brain pathways. So it's not about relearning, it's about fixing what's been broken. So not about like creating new, necessarily. And the exercises, again, it varies, it really depends on what's been affected. But 35 to 40% don't look like they even have a symptom of problem, right? They don't look like they have traumatic brain injury. You could look like me and you would never know. Much of the fatigue comes from overuse of cognitive energy, as we said, and certain tasks may no longer be automatic. So if they're not automatic, then there's something called a manual takeover, where now we have to think of every little thing we do to complete that task. That's exhausting. So a lot of people that suffer from that, they get up, get dressed, make coffee in the morning, and then they need to take like a 2-3 hour nap, because that is so draining. Because they don't know, they can't think. Just, you can compare it to learning how to parallel park when you were 16 years old, and how much effort that took you, right? And now you can just like, you don't even think about like, oh, you don't get anxiety about parallel park, you just do it, right? So now it's really automatic. So you see how it changes. So she actually emailed me 2 chapters of her book, which was really nice. So I went through them, and the first was how to become your own therapist, right? A lot of what we teach our patients or our clients is how they can integrate these tools. So you assess 6 foundation skills, you test your functional limits, which include memory, social communication, word retrieval, reading, comp, and sleep. And you basically manage your fatigue by awareness and monitoring your cognitive energy. So you predict, plan, and pace using a 5-point scale. So as you're doing a task, you assess your energy. 5, being full energy. 3, you're starting to slow down, and 1, you're overloaded. So as you go through a day, if you make breakfast, do an errand, and come home and you're at a 1, that could be too much for you at that point. So it's really about predicting what your day is going to look like, and you really have to plan when you have this and make sure that you kind of stay in that 5 to 3. And when you notice you're slowing down, that's when you start to be like, okay, this is my limit, right? It's not about pushing all the way to our edge sometimes that we do in like a very strong asana practice, but rather creating endurance. And then again, I have mentioned before, you restore your energy with automatic function. So that could be napping, but that also could be listening to music without words, something instrumental that doesn't require the brain to work. That could be running if running is a very automatic thing for you. That could actually boost your energy. So from an Ayurvedic perspective, I talked to Felicia Tomasco, and very interesting, a lot of the things that she said from Ayurvedic perspective really matched what has been recommended for TBI nutrition. So whenever there's a trauma, the vatas get thrown out of balance. So that's why you'll see things show up like anxiety and fear and fatigue, because vata is out of balance. So things that are grounding are really helpful. Vata being the energy of change, right? Talk about a change when you suddenly can't wake up in the morning and make your coffee. So things that are really grounding, like self-massage, so really massaging hands and feet, finding that connection with the things that root you. A warm water bottle in the abdomen at night can be very calming and soothing. We talk about the belly being holding a lot of our anxieties and our fears. So soothing the belly and the abdomen can be helpful. Again, possible foods and things like that to nourish and ground vata. We saw this again with the Western approach, which is essential fatty acids. Again, getting that from flax, hemp, purslane, avocado, coconut oil, the eggs, the choline found in the egg yolk. Herbs such as turmeric and ashwagandha are known for nerve repair. They're also a tonic for the adrenals. Holy basil increases the body's ability to digest that life force, that prana. And it's a tonic for the nerves and the adrenals. And then again, we see ginkgo as an increase of circulation in the small capillaries. Minerals such as calcium and magnesium supporting muscle function. Essential oils could be really helpful. Frankincense and rosemary can be anti-inflammatory, help improve memory. And Shaktapushti, it's a classic Ayurvedic brain herb used for depression, agitation, inflammation. Tryptophan and B vitamins to increase serotonin. From a yoga therapy perspective, I interviewed one, Cindy Miller. She works with a lot of TBI patients one-on-one, so I thought that was helpful because it's very individual, and then we'll show like how somebody actually worked with a group. So she would always start with people. She says that everybody shows different signs as we now know, and she'd always have them take their shoes off so they can have a sense of grounding and a relationship with the earth. Lots of patients expressed anger. She said almost every single person expressed anger and irritability and not feeling normal and never going to feel normal again. So she would always begin with some self-observation to help them reconnect with their body, notice the breath, where they're holding their breath. She would do basic belly breathing, and if that belly breathing was difficult, she would just enhance their normal breath pattern, bringing awareness to certain places with touch, maybe self-touch, or if they couldn't do that, she would always ask if it was okay to have her hands on them. She would use essential oils, which I thought was interesting. She thought frankincense and lavender. She would always start with that, and she said the men seem to connect much more with the frankincense. Movements, again, depending on the patient's ability, could be restorative movement. If they can't move their limbs because their motor functions have been disturbed, she would do assisted movement with them. Heart openings, she said that were very effective. Seated forward folds help to release the feel of any lower back discomfort, any cervical spine discomfort. And then movements with props, for example, if you couldn't move your left arm, then she would maybe tie a strap and you could move the left arm with the use of the right arm. So giving them that sense of being able to have control over an affected limb. And then in a group class, the biggest my takeaway that I received from this was just to keep it simple. Again, we don't know where people are functioning. So we don't want to, we can very easily give so many cues because we want to teach so much, and then that's just cognitive fatigue. So keeping it simple, super important. If they need a chair, having a chair nearby, and modified sun salutations, moving the joints through full range of motion, balancing, leg strengthening, again you find grounding there, and a long nice shavasana to relax and restore and calm vata, calm the nervous system. So my case study, she actually had damage to her frontal lobe due to multiple concussions, very much of a history in 2002, 2003, 2008. She actually wasn't diagnosed until 2013. So that's insane, right? That's a really long time to be suffering from a traumatic brain injury, going undiagnosed, but showing all these other symptoms of fatigue, depression, and anxiety, and we're treated for all those, but nothing was changing. So that's where we find the ambiguity, right? And she was just, until literally she actually was in a 1.5 years of law school, has no recollection of ever being in law school, so she's missed out on 1.5 years of her life. She has no idea. She'll look at pictures and doesn't even recognize or remember when they happened. She doesn't even know how she made it through the 1.5 years of law school, and to the point where, you know, the reason why she went to that neurologist was when she was sleeping for 2 weeks at a time and then eventually starting to lose her ability to read. But you can see 2002 was the first one, and then 2013 was the diagnosis. So you can be living with a brain injury and getting more and more severe for